In this video, we will find out about the mini gastric bypass, also called the one anastomosis gastric bypass. We'll find out what it is, how does it compare to the Roux-en-Y gastric bypass, which patients would benefit from it, what is its efficacy in terms of weight loss, type 2 diabetes complications, and reversibility. Firstly, how does it work? Here is a standard configuration for a human. Food comes down the gullet into the stomach. The stomach churns it up and passes it down into the duodenum. The bile comes down the bile tube to digest the fat. Pancreas produces 90% the enzymes that digest the food, and they come out over here and meet with the food. Jointly, this is called the biliopancreatic secretions. And the food, as it's broken down, is absorbed in the small bowel. In any weight loss surgery, there are two main objectives to achieve. Firstly, it means that there is less volume for the food to arrive in the stomach, thus making the stomach a lot smaller. And you can see in the one anastomosis gastric bypass, the stomach has been partitioned, leaving only 20 to 30 mils of stomach volume so that the patient feels full very quickly. The second one is malabsorption. If these secretions don't meet with the food goes undigested, and that is the point over here. The food arrives in the stomach and goes straight into the small bowel without meeting with the juices in this segment, so there is less of the small bowel, called the common channel, available to digest the food, thus leading to malabsorption. Not enough of the nutrients are absorbed, thus leading to weight loss. And why is it called the mini gastric bypass or the one anastomosis? Because there is only a single joint over here after partitioning of the stomach. This is the Roux-en-Y gastric bypass, the traditional popular gastric bypass, and you can see in this too the stomach is partitioned. There are two joints, one with the stomach and another one further down over here. So the mini gastric bypass supposedly associated with a lesser risk of complication. The proponents of the mini gastric bypass argue that this is less complex procedure and consequently associated with fewer rates of complications while achieving the same objectives of weight loss and control of type 2 diabetes. So who would benefit from it? And the indications are the same as other weight loss procedures. After patients have been on a multimodality program to lose weight for at least between 3 to 6 months of diet and exercise, and they haven't lost the weight, then they would be candidates if their body mass index is greater than 40 or greater than 35 with a risk factor which is cardiovascular, type 2 diabetes, sleep apnea, osteoarthritis, etc. Those with uncontrolled type 2 diabetes, a lower BMI may be accepted for performing weight loss procedure. South Asian population, the indications are a BMI of at least 2.5 less than for the European and Northern American populations. Now, who should not have this operation? These are patients with high anesthetic risk, those with psychiatric disorders such as eating disorders, and those in whom the blood clotting would not allow the procedure to go through. In terms of efficacy, over 2 years, 60 to 75% of excess weight loss has been reported in patients who undergo this operation, and up to 70% of the patients with type 2 diabetes achieve remission. These figures are very comparable to those with Roux-en-Y or the traditional gastric bypass. Patients are at risk of the complications such as leak from the joint or from the end where the stomach is stapled, dumping, where when food arrives, especially the high carbohydrate, high sugar food, patients may develop sweating, anxiety, palpitation, and diarrhea. Strictures may form at the joints, risk of future hernia and obstruction, and of course nutritional, specifically micronutrient loss and deficiencies may develop. And these are more pronounced. Segment of the bowel where no absorption takes place, called the biliopancreatic limb, is longer than what is generally accepted, which is between 150 and 180 centimeters. What about reversibility? It is possible, but as you can well see, the complexity that has been engendered into the operation, it will require another complex procedure to undo the mini gastric bypass. In conclusion, it offers a potentially simpler solution to the more complex Roux-en-Y gastric bypass, and at least the initial reports of a good few number of patients are encouraging in producing similar results and outcomes. Further data on head-to-head comparison between a mini gastric bypass, the Roux-en-Y gastric bypass, and the sleeve gastrectomy, which are the commonest procedures performed, certainly be useful to inform patients in the future. This completes this brief video. If you have any comments, please do share.